How do we treat hip fractures? This is part 3 in my series of the basics of hip fractures for new orthopedic students, whether you're a PA or nurse practitioner or a medical student. Before I was a board certified orthopedic surgeon, I was a medical student, absolutely lost and terrified to ask a question. So you don't have this feeling. I'm making these series of videos on the basics of orthopedics. So let's get into part 3 of our hip fracture talk. This is part 3 of hip fractures for PAs. In the first video, we talked about how we determine whether we replace or fix these fractures. The last video we talked about the fixation options, and today we're going to talk about replacement options for hip fractures. So just in review, if we have proximal femur, we talked about the very important blood supply at the base of the femoral neck, at the basocervical region, which gives these blood vessels. And if we also talked about the capsule. So that line actually demarcates where the hip capsule ends. That's just like an encasing of that hip joint. And so if we fracture through the neck, either the transcervical, through the neck, transcervical, or just below the head or subcapital, we are risking that head not surviving. If we're pretty sure that's not going to survive, we're going to replace that. And so replacement options are going to be for fractures in the capsule, which we call intracapsular fractures. That includes the right below the head or subcapital, through the middle of the neck, which we call transcervical, and even as an asterisk, some of these base of the neck or basocervical. If these fractures are completely displaced, as in the head is no longer attached to the neck or the rest of the femur, we're going to replace these pretty much 100% of the time. In the circumstance where it's non-displaced or minimally displaced, well, some we will replace and some won't, and that's more advanced than this lecture is going to talk about. But in general, about 25% of these we will replace, and that is very surgeon dependent. So there's 2 ways to replace a hip that is broken. We can replace just the ball of the ball and socket, which is called a hemi-arthroplasty, or half a hip replacement, half an arthroplasty. Or we can replace both the ball and the socket, what we call a total hip arthroplasty. So those are our 2 types. So if I had to draw it, say this is our broken hip. So we're going to take that dead head or dying head and we're going to throw it in the garbage. Going to kind of freshen up the cut, and in place of that bone, we're going to add a metal ball. And how that metal ball stays in place is that there's actually a stem that goes down the femoral canal. The rest of the hip just rests in the patient's normal hip socket, the normal bone and cartilage. Now, for the total hip replacement, say this is our broken hip, broken femoral neck. The first step is the same. We're going to get a metal ball, put it in its place. We're going to put the stem down into the femur. But the difference is, in this case, we also will replace the socket. So the socket looks sort of like a cup. So in this place, we're also going to replace the socket. So replacing it's a total hip. It's the socket, also called the acetabulum. Acetabulum, people just call it a cup. And we're doing the ball, replacing the ball or the head. Now, why would we choose one or the other? What determines why the surgeon will pick one or the other? Well, let's talk about the pros and cons of both. Well, the main pro, the main reason we do these is that, number 1, they are an easier surgery. I'm not going to say easy, but easier. They're shorter. There's much less blood loss. It's easier for the surgeon and also for the patient. So you can get them in and out of the OR relatively quickly. The other advantage is that it's more stable. Another way to say that is there's fewer dislocations. So this ball can pop out of the socket. It happens. It's unfortunate. It happens more with a total hip. So this is much more stable. Now the downside of the partial hip replacement or the hemiarthroplasty is that this metal ball can wear out the socket. So I'm going to put, it can wear out the socket. Now that takes a long time, more than 10 years, so in most cases that's okay. So now let's talk about the total hip arthroplasty. The main advantage is that we are solving this wear problem. And so in order to avoid wearing out the patient's cartilage and bone, we say, why don't we just replace the socket or the acetabulum? So it's better wear, so you don't have to worry about wearing it out. We know total hips will last 20 plus years. That's the main advantage of this. The downside of total hips is that it's a much longer surgery. So the surgery is complex. There's more blood loss. If you have to divide these into half, the acetabular side, the socket side of the surgery, is much more technically demanding than the femoral head side. So it's a much more complex surgery and it's more unstable. So you're going to have more dislocations, and dislocations in these patients are pretty problematic. If we can't get them to stay in, you need another revision surgery. It's a major problem. And so how will we decide? So I think when you're thinking about these patients and maybe seeing them on the wards, the first thing you need to worry about is their general health. So health. Can they get through this big surgery? We're talking at least an hour more surgery, more blood loss. If the patient is not healthy enough to get through this big surgery, well, we're going to do a hemiarthroplasty. So if they have heart disease, they have heart failure, maybe they're on blood thinners, you sort of want those patients in and out of the operating room, so they're going to get a hemiarthroplasty. Second thing to think about, and you discover this taking a history, is their activity levels. So if you have a patient who doesn't walk much, maybe they're already using a wheelchair for certain things, they don't need to worry about wearing out this acetabular side. So they will do just great with a partial hip replacement. If on the other hand, you have a patient that walks 8 miles a day and plays pickleball 3 times a day, well, they might wear out this socket, in which case you're more likely to give them a total hip replacement. The third one, and I'm putting it third for a reason, is age. Now, age is just a corollary for health in general. Health is way more important than age, but as a general guideline, it can be helpful. Now, the cutoff, based on recent studies, is 75. Someone did a recent study to see which one of these hemiarthroplasties eventually needed a total hip arthroplasty. And if they were younger than 75, there was a higher risk of wearing out this hip. Now, again, that's just a guide. If you have a 75-year-old who has heart failure and diabetes and barely walks, well, they probably will still get a hemi. If you have an 80-year-old, but they play tennis and play golf and walk 10 miles a day, well, then they probably are more likely to do better with a total hip replacement. So this is just a guide, but an important one. So in the extreme cases, if someone's 55 years old, well, they probably should get a total hip replacement. If someone is 95 years old, well, they probably need a partial hip replacement. And the final one, which maybe is you might think about less, is the stability question. So to avoid having the hip pop out of socket, there are certain precautions we take. There are certain instructions we give patients. Now, if they can't follow those instructions, well, then we maybe we're more likely to give them the safer, the more stable option, which is a hemi. Those can include things like dementia. If someone has dementia and they can't really follow the directions, well, then we're more worried about dislocations. If that patient maybe has a movement disorder like Parkinson's disease, well, I'm more worried they're going to dislocate. So then we're going to offer them a hemiarthroplasty. And the other one that's maybe you don't think of is they have a very stiff spine for whatever reason. They've had maybe major spine surgeries or spine fusions. Well, they are a higher risk for dislocating, so you're maybe less likely to give them a total hip replacement. This is very surgeon dependent, but important that you gather this information if you are on the wards seeing these patients. Get a picture of their health, get a picture of their activity level, and get a picture of any other risk factors like if they're demented. So that's the basics of replacing hips. If you want to stop right there, that's great. Now, I'm going to add a little bit of a bonus part to this talk because there's two types of hemiarthroplasties that it's helpful to know about. So let's talk about this. So when it comes to hemiarthroplasties, there are two types. The original type was, so this is a broken hip, the original type, and I'm going to draw another one right here. The original type was just a ball. It's just a ball and a stem. Simple as that. Someone thought theoretically, well, what if we made a ball within a ball? Like, so this ball is just in the cup. Now, if we made it look more like a total hip replacement or made another surface for the hip to rotate around, it would be more stable. So I said, okay, well, that's not a bad idea. So someone invented a ball within a ball construct. So you have a littler ball that looks something like this, and that sits within a bigger ball, which looks something like this. So there's a piece of plastic in between. So this ball will spin within this one, and this ball will spin within the patient's native bone, like this. We call this first one unipolar, like a unicycle, like one bike. And then we call this a bipolar. It's like a bicycle with two wheels. Here's my bike. Here's my unicycle. So a bipolar hemiarthroplasty is a ball within a ball, and a unipolar is just a ball. The theoretical advantage, more stability. I say theoretical because actually when they did the studies, it made no difference. So this is a theoretical advantage. The disadvantage is that this is very expensive. It's much more expensive than the unipolars, of course. Depending on your institution, the bipolar hemiarthroplasty might be the standard for fixing hip fractures. So just so you know, when someone says putting in a bipolar, that's what they're talking about. They're talking about a hemiarthroplasty that's a ball within a ball, and it gives you a theoretical advantage in stability. But actually, if you look at the science, it doesn't make a difference. Hope this is helpful. If you're watching and you have any questions or you want to have anything else presented in this way, you can send me an email. My email is willkangaroo@gmail.com if you have any questions.